Without further ado, I would like to introduce our speaker for this evening, Dr. Sam Pullen. He's an assistant professor of psychiatry in the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. He's a child and adolescent psychiatrist certified by the American Board of Psychiatry and Neurology in child and adolescent psychiatry and general psychiatry. He received a master's in public health from the Johns Hopkins School of Public Health, a master's of science in biomedical sciences from A.T. Still University, Kirksville School of Osteopathic Medicine in Missouri, and his Doctor of Osteopathic Medicine from A.T. Still University, Kirksville School of Osteopathic Medicine. Please welcome Dr. Pullen.
All right. Well, thank you very much, Karen and Bryn, for that welcome and your assistance with this presentation. Good evening, everyone. It's a pleasure to be with you this evening. Like many of you, I'm just finished up with clinic, and so it's such a great way to end the day to be able to talk with you about really what's one of my favorite topics and favorite conditions to treat. We see a lot of children and adolescents struggling with anxiety disorders, and we partner very closely with our primary care colleagues in the care of this patient population. So I hope that this talk will be of use and benefit to you in your own practice. As was mentioned, I don't have any financial affiliations or conflicts of interest to disclose. And these are our learning objectives. We're going to spend just a little bit of time talking a bit about kind of an overview of anxiety disorders in children and adolescents. And so we'll talk a little bit about just the prevalence. We'll talk, just touch on some of the neurophysiology of anxiety disorders, mostly for the purpose of setting up what's going to be the bulk of our conversation this evening, which is going to be around assessment. And then we're going to get some dive into quite a bit the role of treatment, and in particular, your role as primary care providers. And there's quite a bit that all of you will have to offer the care of this patient population. So before we dive into this kind of three-tiered lecture this evening, I wanted to begin our talk with a case that I saw at the really shortly after I had graduated from my own training program. I was practicing in Idaho at the time, so a large rural area, very limited resources. And one of the first cases that came to my clinic at that time was the case of an 8-year-old young man. And he was brought in by his parents, or I should say, they attempted to bring him into the clinic by his parents. This young man actually was refusing to come into our clinic. And so basically was, when I found him, he was really throwing quite a hefty temper tantrum and was out in the car that his parents had brought him in. And his parents were profusely apologetic. They were trying their best to get this young man into clinic so that we could do his evaluation and assessment, but they were in desperate need of help. And so, so we actually ended up doing his initial evaluation out in the parking lot rather than having him come into the clinic that particular day. And the brief, just to kind of give you a brief synopsis of the key points of his case presentation, this young man was having increasing behavior challenges that were marked by recurring temper tantrums that really tended to start on the weekends and worsened by Sunday evening. His presentation was marked by pretty significant school refusal. He had missed a large number of days in school and was really in danger of not being able to successfully complete his particular grade in school. So he was in danger of being held back. His parents shared with me that his sleep was quite poor. He was constantly in need of reassurance, constantly checking to make sure that his parents were okay, was very fearful of separating from his parents, and school was a big hallmark and indicator of his fear of separation. His parents, his father was an employee of the hospital, the health system that we both worked at. And his parents, were leery of medication, of psychiatric medication. And so they were not completely opposed to it, but they definitely had lots of questions about that. And he had never received any kind of treatment before coming to see me in clinic. And so that was really the case presentation. I'll skip to the very end, and the middle part of that case is really going to be referenced back as we go through this presentation today. But by the end of his treatment course, which lasted about 8 months or so, was about how long I followed him for. He was back in school full-time, was no longer having any of these significant fears, was doing so much better at both home and at school. And I'd like to present this case, one, just because it sets up what we're going to talk about today, but two, this really kind of is such a good illustration of just how treatable anxiety disorders are, and how much impact that you as primary care providers who will see the vast majority of cases like this can have on this patient population. So you can really make a huge difference in the lives of kids. And it's really about following the same evidence-based treatments and practices that we're going to talk about today. So let's dive in. So briefly, I just wanted to go over a little bit of neurophysiology here, and just talk about some of the key chemical messengers that are implicated in anxiety disorders. As many of you are probably aware, serotonin is probably one of the main players in anxiety disorders, and that's really is a good reason why we use SSRI medications so much in the treatment of anxiety disorders. Serotonin has a significant role to play in regulating our mood, our emotional state, our appraisal of the environment, whether the environment is safe, whether the environment is something that we need to be, something in the environment that we need to call attention to. It plays a significant role in sleep, appetite, and so forth. So serotonin is definitely a key player. Dopamine, and there are several dopaminergic tracks that are associated with anxiety disorders. In particular, I usually call out the mesolimbic tract. So in our limbic system, this is really where a lot of our fight or flight response is originating from, is occurring. So you've got a lot of important structures in that system, the amygdala, of course, that are really important in that fight or flight response. And that's really, when we talk about anxiety, that's really kind of the end product, if you will, of the activation of our fight or flight response. And that our brain is constantly appraising the environment to determine, do we need to be aware of something? Is something important that we need to be focusing on and paying attention to? Our brain plays, of course, a critical role in keeping us safe and protecting us from the environment. And so this has a significant function that anxiety in the limbic system serves. Norepinephrine is associated with a lot of our autonomic responses as it pertains to anxiety. And so much like with serotonin, we see important physical complaints, physical symptoms associated with anxiety. And I like to think of these as our kind of our midline symptoms. So starting from our head, going all the way down, you can get a number of physical symptoms elicited on examination that are associated with anxiety disorders. And sometimes, your patients, your parents will attribute these to medical conditions or will be very concerned about medical conditions. But this is an important role in anxiety as well. And this is important to educate our patients too. GABA, and simplistically, I think of the GABAergic system as kind of the braking system, an important braking system in the brain. It's an inhibitory neurotransmitter, and GABA has anti-anxiety effects. So medications that are GABAergic in nature, so our benzodiazepine medications, for example, gabapentin, and so on and so forth, can have anxiolytic effects. And decreased GABA can have the opposite effect in terms of promoting symptoms of anxiety. That's really all I'll say about this part. I want to get into a little bit about some of the symptoms, and I described some of that in the case that I presented. So these are things to ask about when you're doing your own assessments for anxiety disorders in pediatric populations. This is not an exhaustive list of symptoms, but these are some of the more common ones that you may see. And you'll often see, I won't read through all of these, but you'll often see behaviors associated with these symptoms. And so, and these symptoms may not be the ones that parents and patients are coming to your office or your clinic with complaining of, but it's often the kind of in the context of behaviors that they're noticing. So you may see, avoidant or oppositional behaviors, acting out, temper tantrums, and so on and so forth. So you really kind of have to oftentimes do a little bit of digging and detective work to really kind of get at some of these symptoms that can really point you in a direction of whether this child may be having an anxiety disorder. I wanted to share just a little bit about prevalence of anxiety disorders, and you can see this compared to depressive disorders and behavior disorders. And in this particular graphic, behavior disorders are defined as kind of our externalizing behaviors, so oppositional behaviors, behaviors that you might see associated with ADHD and so forth. So that's just to kind of define what we mean by behavior disorders in this graphic. And you can see the breakdown by age groups and the prevalence of these conditions. And of course, what stands out to you is that your anxiety and your behavior disorders start pretty early on in age. And then really by latency age, you're seeing a big increase in both behavior and anxiety disorders. And in adolescence, anxiety disorders really peak, making anxiety disorders the most common psychiatric condition that we see both in primary care settings and in specialty practice as well. So, so this is definitely something that you all are going to see in your practice. And this is probably the most common psychiatric presentation in primary care settings. So this is my, these are my own photos. This is kind of the analogy that I like to use because sometimes as you're explaining, your treatment plan, what you're trying to accomplish in the care of your patients, especially patients and parents who may be somewhat skeptical of your treatment plan and why are you doing what you're doing and what's kind of going on here. So this may also resonate some with you all being on the eastern part of North Carolina, so certainly being closer to the beach. But I like to sometimes compare anxiety disorders just to the waves of the ocean. And just like, you have waves are just a normal feature of the ocean, and there's we have they're easily explained, and so on and so forth. That's much like anxiety, and again our fight or flight response in our brain. This is just a normal protective function of our brain, just much like waves are just a normal feature of the ocean. And so we want to be careful not to pathologize, normal anxiety or anxiety that kind of exists on that spectrum. But sometimes, every so often, we get things like earthquakes, or we get things like hurricanes, or we get things like, other extreme weather events that create tsunamis. And so that's kind of been my analogy, transitions from what's kind of the normal protective and alerting functions of anxiety to say, hey, this is important, to, hey, this is now becoming impairing, and this is causing a lot of distress and really difficulty with your child really functioning. And that's kind of when a normal sized wave goes to a tsunami. And so why I like this analogy so much is that then you can kind of transition to, this is what we're trying to accomplish with our treatment plan, right? And so your treatment plan may involve referrals for therapies, or you may have a social worker in your own clinic that provides therapy services within your own clinic setting. It may involve medications that you want to talk with your patient and the parents about potentially starting, because your goal is going to be, can we bring that tsunami down to a more reasonable level, right? So that might be our goal with medication. And then with therapy, oftentimes I like to use the analogy of teaching your child to surf or bodyboard. Right, so that they are really kind of mastering that anxiety, and so you kind of are using that. I like to use that analogy. That often resonates with my patients, particularly those that love going to the beach. Sometimes I have to find a different one that works, and of course you'll find maybe something that works in your own practice and clinic setting. But I just like to use that for purposes of illustration. Okay, so now we're going to dive really into, I think, the meat of this presentation today. Before we ever talk about treatment, before we ever dive into what medications to pick, what are you going to recommend for your patient, or what treatment or service are you going to refer them to? I cannot underscore the importance of doing a really good assessment. And this is something that all of you are already, experts in. And much like you would do a thorough assessment with any medical condition that presents to your clinic setting, we're going to follow kind of that same process here for anxiety disorders, right? So we're going to do things like reviewing their relevant history. We want to know about past medical history, medications. Is there a family history of anxiety disorders on mom's side or dad's side? And that may be important for a couple of different reasons. Is there an underlying kind of predisposition towards anxiety? Is that limbic system and that fight or flight response tend to be more sensitive, for example? Or do you have a parent that they themselves struggle with anxiety disorders, and is that something that the child's kind of picking up on? So there's lots of different reasons you might want to go through that. Assessing function. And we do a course called the REACH course that I'll talk about here in a little bit towards the end of this talk. But we teach a lot about using screening tools and rating tools in your clinic setting. We don't have labs that specifically you draw a lab and say, aha, this is an anxiety disorder. But we do use screening tools to really help give us a good assessment of baseline symptoms. And then that also allows us to track effectiveness of treatment over time. Always important to assess for safety. So you want to assess for safety, both from the standpoint of, is there any concern or risk for suicide, for example, or self-harm behaviors? Is there any concern or risk for, for any abuse that may be occurring? So thinking about, trauma, neglect, abuse, you can certainly see that, and a lot of those anxiety symptoms are going to be hallmark features of trauma. So you want to make sure that you're doing a good safety assessment there. You want to assess for high risk behaviors. So safety is such an important part to this assessment. Some of the rating scales that I like to use in my own practice and that we also teach our primary care providers to use are things like the SCARED, which is the screen for child anxiety related disorders, the PSC-17, the pediatric symptom checklist. I like to use the CRAFT in my adolescent populations to screen for substance use, and also, of course, the PHQ-9, which many, if not all of you, use currently. And we'll go over those screening tools in more detail as well. And so these are just some important things to think about in your own assessment. Oops. So these are some of the things. This, again, it's not an exhaustive list, but just to kind of get you thinking a little bit about your differential, especially if you're seeing, when you're seeing this child for the first time in your clinic. It's important to rule out or to consider co-occurring medical conditions. So you want to think about autoimmune conditions. In my own clinic practice, I work in our autoimmune brain disorder clinic. So these are going to be a little bit more, zebra-ish, if you will. So they're not going to be more of your run-of-the-mill. But we certainly see anxiety and agitation in this patient population. Something that I ask especially my adolescent patients about is caffeine. I want to know how many energy drinks they're drinking, how much Mountain Dew they're drinking, how much coffee they're drinking, tea, and so on and so forth. And so it's oftentimes that we forget to ask about caffeine, but such an important substance to think about. Certainly thinking about migraine headaches. Asthma is probably one of our most common co-occurring medical conditions. And there's certainly some obvious reasons that we can, associate asthma and anxiety with, but it's certainly something that we see commonly co-occur. And we also want to think about cardiac related conditions, neurologic conditions as well. I want to think about other psychiatric conditions. So a lot of our psychiatric conditions, as they present in pediatric populations, we often will see a lot of overlap. And so one, because they either co-occur with one another, or two, because it can be hard, to tease out initially, is my child inattentive or restless, because they have an ADHD presentation, or is it something that's more connected with an anxiety presentation? A good, careful assessment where you're thinking about, when this is occurring, is this an episodic phenomenon that occurs? Is it only occurring in certain situations or settings? That can really kind of help steer you in the right direction. But co-occurring conditions in the world of psychiatry tends to be the rule rather than the exception. So also don't forget to kind of consider co-occurring psychiatric conditions. And then, of course, you want to think about psychosocial settings, right? The environment. So, think about substance use, a really important thing to ask about in our older child and adolescent population. Certainly thinking about legal issues, thinking about, living conditions, thinking about bullying at school or on social media, for example, thinking about, in your female patient populations, pregnancy, and so on and so forth. So just wanted to share some things that you'll want to take into consideration as you're doing your assessment. So these are some of the screening questionnaires that we use in our practice here at Duke. This is something that we teach our primary care colleagues to use when we're doing courses like this. And these can be really helpful tools to help really kind of get you the information that you're needing to make those clinical assessments, to be able to track symptoms over time, and can really help, especially in a busy primary care setting and practice, can really help kind of consolidate your time. So there's a lot of utility to using screening and rating tools. The ones that I've highlighted here, the pediatric symptom checklist, the SCARED that I had mentioned earlier, and then the CRAFT. And certainly we can talk more about what some of our other colleagues have done to incorporate using these tools in your practice, but something I would definitely recommend. Just wanted to share a little bit more about the SCARED, just because this is a tool that I probably most commonly use for assessment of anxiety disorders in children and adolescents. This is a tool that's free on public domain, so any of you can just download the PDF. There's a parent and a child self-report instrument that will take you through generalized anxiety symptoms, separation anxiety, panic disorder, and social phobia. A lot of times, what we'll share with our primary care colleagues is not getting so caught up in, is this generalized anxiety disorder, or is this social phobia, or is this separation anxiety disorder, is this with or without panic disorder, right? So not getting caught up in the diagnostic minutia so much, because our treatment approach for anxiety disorders, regardless of the flavor, is going to be the same or very similar, right? There might be some nuance, that you might consider, but I wouldn't worry so much about getting into the diagnostic minutia of what kind of anxiety this disorder this is, so much as making sure that you've done a good assessment and that your treatment plan matches that. So it allows, it's 41 questions, right? And the cutoff score, it's not listed here, but the cutoff score for clinically significant symptoms of anxiety is 25 or greater. And so if I have a child that's scoring 35, 40, and both the child and the parent are scoring kind of in that range, then I'm not so much worried again about what kind of anxiety disorder this is. I'm saying, hey, look, I think there's some pretty clinically significant symptoms of anxiety here. Let's talk about what we might want to do as far as a treatment plan goes. This is something that's easy to administer. And you can, I often do this while patients are in the waiting room or while they're checking in with my nursing team, so that by the time they come to me, they've got that form filled out and we can kind of go through that together. The nice thing about this form too is it comes in different languages. So it, you can use it for a lot of different populations. So continuing our journey as far as assessment, as we start to think about, okay, we've landed on anxiety. We definitely think, like my young man that I talked about at the beginning of this, definitely this seems to be some separation anxiety. Maybe there's some social phobia going on here. This kid has definitely got clinically significant anxiety symptoms that are impairing for him. So now as we start to talk about treatment, I segue my approach into treatment. So I don't usually just start talking about SSRI medications, once we've landed on a diagnosis. Now we start kind of thinking about, okay, how do we start partnering with this child and the family? And so that's that, and I kind of use that still as part of my assessment, and then segueing into my treatment approach. So we kind of think about, okay, who's on our team here? Who do we need to start thinking about and including in our team approach here? So as we think about our developmental and contextual assessment, we're going to think about who all's in the family. Who all do we need to kind of think about and consider? What's happening in the family that we need to think about? What kind of education do we need to be providing? And who can be our partners? The school. And a lot of times when you're dealing with anxiety disorders, especially with younger kids, you're going to be dealing with some element of school avoidance. So the school's got to be a really important partner in your team. We're often talking with a identified person at the school, whether it's a teacher, principal, school counselor, whomever that person is that knows the child, knows the family, that the family's contacting regularly. That's who we want to kind of partner with. And we want to think about community partners, who's available kind of in your neighborhood and in your communities and so forth. So that's kind of, we're starting to think about who's on our team here. I mean, are there other providers that we need to be thinking about that also need to be brought into, into this, to help us, with either treatment or further assessment and so forth. So that's, I think, if I could leave you with a takeaway on assessment, right? It's not only about developing your differential and kind of honing in on that, but you want to think about, okay, I know what the evidence-based treatments are. We're going to go over that here in just a moment, but how do I get that implemented? How do I build a working alliance with my, with my patient, the family, and whoever else needs to be on our team? So that is really critical to successfully treating anxiety disorders. This is, I put this in here. It's not normally part of our anxiety disorder lecture series that we give, but I really love this approach. This is the approach I like to use when I'm trying to build a therapeutic relationship and partnership with families, especially skeptical families, families that have lots of questions, families that maybe don't have the best health literacy. This is a motivational interviewing technique called LEAP, and it's something that can be done in a primary care clinic setting. There's YouTube videos you can look at and see how this is done. If you take our REACH course, we demonstrate how this is done as well. For the interest of time, we won't do, and because I don't have somebody else that I can partner with, I won't demonstrate it today. But the acronym stands for listening, right? Empathizing and engaging, educating, and really kind of being open to exchanging ideas, right? So your family is going to be an important source of ideas that they may have. And so this is kind of a bi-directional approach. You want to try and find areas of agreement, and sometimes that can be hard, especially if you've got family that are skeptical of medical intervention or skeptical of medication. You might have to work a bit harder, but oftentimes, as you're kind of building that relationship, you will find areas of common ground that you can agree on, and that's where you want to start from. And then it's the partnership and the planning, and then moving, kind of being action oriented, as I like to say, rather than than just kind of allowing your patient to languish. We really want to once we kind of have things in motion, we really want to partner and move ahead with the treatment plan. But this is such an effective and I think important technique that you can all use in your own practice. Okay. We're going to start diving into now treatment, and the recurring theme, and this is not just anecdotal, but this has been borne out in all of the big studies that have been done looking at anxiety disorders and their treatment and effectiveness in pediatric populations. It is often more than just one approach, especially for severe anxiety disorders like my patient that I shared with you at the beginning. So it's going to be a multimodal approach. You might be thinking about medications, but you're also going to be thinking about, therapies. You're going to be thinking about, okay, what do we need to do to help this child improve their sleep? What do we need to do to help improve their learning in the school setting? Because that may be a function of their anxiety and really affecting their confidence. Do we need to address a parent's own anxiety, for example, and help them out with their, so this is going to be pulling all of this together as you're putting your treatment plan together. So really kind of be thinking about a multi-pronged approach here. So you want to think about as you're approaching your treatment strategy, you want to think about severity and how impairing is this anxiety disorder. Are they missing lots of school? Is it causing severe behavioral challenges at home or in other settings? Are they at risk for some kind of bad outcome, if you don't intervene? So again, like my child that I presented at the beginning, they were pretty impaired. They were not going to school, were missing more school than they were attending, and we really needed to take pretty aggressive action. So that's going to be an important factor in dictating how aggressive you're going to be in your treatment approach here. And so my approach with them was to combine medication and psychotherapy, and we'll talk through kind of some of the things that we did with that. There's several really good studies out there. Just the one that I want to highlight for us is the CAMS study here, and you see this referenced here. This was by a group. Some of our colleagues here at Duke were involved in this study, including Dr. Scott Compton and Dr. Moya Rin, who's our department chair. This was a really important federally funded study that gave us a lot of information about systematic and evidence-based approaches to treating anxiety disorders in pediatric populations. So this is the gist of the study, and this is a slide that I added at the last minute because I was fussing with the presentation a bit, as presenters are prone to do. But I just wanted to make sure to kind of give you the highlights of this study. As I mentioned, this was a federally funded study. This was a multi-site randomized controlled trial looking at almost 500 youths. So this is a large study, right? A multi-site randomized controlled trial. Duke was, again, one of those sites that we did this at. And these were children between the ages of 7 and 17 who had anxiety disorders, where OCD was an exclusion criteria in this case. So these were kind of our separation, basically our scared questionnaire anxiety disorders, right? And so this is a 12-week where they received cognitive behavioral therapy, sertraline, combination of CBT and sertraline, or a placebo. So they were randomized to one of those 4 treatment arms there. And then they used some different research tools, the clinical global improvement scale, pediatric anxiety rating scale, to really kind of gauge effectiveness of treatment over that 12-week period. And what they found, and this has played out time and again in different studies as well, combination was better than cognitive behavioral therapy or medication alone. Medication and cognitive behavioral therapy were not different from one another, but all of the treatments were clinically or statistically different than the placebo arm there. Another key takeaway from this study is look at the dosing of the sertraline. So these are kids ranging in age from 7 to 17. And so look at the average dose of sertraline. It's close to 150 milligrams daily. So this was in the case that I presented at the beginning. Even once we got, so I did start this young man on sertraline, and we got him up to 50 milligrams. And already he was starting to do a lot better. But his symptoms of anxiety weren't in full remission yet. His parents, though, were so ecstatic that they didn't want to do anything with the medication. And this is when I pulled in this study and say, hey, look, I know he's doing a lot better, but his symptoms are not in remission. And so I want us to try and be a little bit more aggressive, because that's really our goal at the end of the day, is to get symptoms as close to remission as we can. And so this was the average daily dose that we really needed to get to get full remission of symptoms. So I wanted to go over just kind of give you a quick overview of the other SSRI medications that we commonly use. And this is just really kind of for your, you can take this slide and kind of post it so that you kind of get a sense of dosing that we use for children, duration, peak effect, indication, and so forth. You don't have to be a master of all of these medications. I usually tell my primary care colleagues, much like our child psychiatry colleagues, right? Pick a couple of medications that are your favorites. And so And they're all going to be effective in treating anxiety symptoms. And in fact, our SSRI medications are often more effective at treating anxiety than they are depression. And so you'll find that in the literature as well. My personal favorites, especially for younger kids, tends to be Zoloft and Prozac. I like Lexapro, especially in my adolescent populations. So those are the three medications I tend to use probably the most of in my practice. Right, so this is just some kind of guidelines to think about when you're using SSRI medications in your practice. I tend to reserve SSRI medications for moderate to severe symptoms of anxiety disorders. For mild symptoms of anxiety disorders, really best evidence is starting off with cognitive behavioral therapy. And so that's kind of typically kind of where I land in terms of when I start thinking about medications. Say you start your child in therapy, but they're not progressing well, or their anxiety is really keeping them from making good progress in therapy, you might think about starting a medication at that time, or if they're only getting partial response to psychotherapy. Now, this is a key piece here. It is important to have at least a good general sense of cognitive behavioral therapy and what that is. Although you're not going to be providing CBT as a primary care provider, you want to be able to at least educate your parents to that on a general level. And you want to be able to ask, hey, is my patient actually getting CBT? Because a lot of times you may hear the generic umbrella term counseling. And for me, sometimes that's hard to know. Well, what kind of therapy are they actually getting? So cognitive behavioral therapy is a very specific evidence-based therapy that is indicated for treatment of anxiety and mood disorders. Okay, that's going to be our general approach to treatment. Now I just want to talk about a few things that you can do in your practice that kind of coincide with some of the things that we are fortunate enough to be able to do here at Duke. So Duke was awarded a large HRSA grant, which has allowed us, one of our missions here at Duke is to really improve the lives of children and adolescents suffering from mental health conditions. And how we do that is we partner with our primary care colleagues across the state, which is one of the reasons I was really excited to be able to talk with all of you today about this. So we're taking a multi-pronged approach to doing that. One of the things that we're doing is doing what's called our REACH program. REACH stands for the Resource for Advancing Children's Health. This is a nonprofit organization that's based out of New York City. It was actually founded in 2007 by my mentor, Dr. Peter Jensen, who trained me when I was at Mayo Clinic, when I was doing my child fellowship training. And actually, I've been a REACH course master since my time in Idaho. So I've been working with the REACH Institute for, goodness, now 6 or 7 years. I mean, I don't have any, financial ties to REACH or anything like that. So this is just been my own experience and partnership with them. But essentially what this is it's a 6-month fellowship that we offer through this HRSA grant to train primary care providers who want to go through this program and learn more about treating children and adolescents with mental health conditions in their own setting. And because of the grant funding, this is free for primary care providers. And so this talk today has a lot of those elements of what we do in REACH, although REACH is quite a bit more immersive than what we can do in our time together today. So I just wanted to share that with you. If you're interested at all in participating in a REACH course at some point, Chelsea Swanson, who is kind of our contact with Karen, is a great person to get a hold of. And she can definitely connect you with that. So if this was kind of whet your appetite a little bit, REACH is, like I said, a lot more immersive. we'd love to have you join us if you haven't done that already. I think some of your colleagues out in the eastern part of the state have done the REACH course, and so it's a wonderful program that that we really enjoy doing. Just another kind of thing to consider as you're in your own practice, right? So collaborative care or integrated care. And there's a lot that goes into setting up collaborative care practices. If you happen to be, part of a health system like Bident, for example, out in the eastern part of the state, talking to your leaders about, doing something like collaborative care and investing in that can be a huge game changer for creating access for patients with mental health needs in your primary care clinic setting. We could spend another hour talking about collaborative care, so I won't do that today because we're just about out of time. But I just wanted to share that as another strategy that you can provide in your clinic, as you're thinking about taking care of patients with mental health conditions, including anxiety disorders. And then the last thing I just want to touch on real quick is this is another piece to our HRSA grant that I had mentioned, which is our NC-PAL line. This is a consultative support line. So my colleagues and I are basically the folks that you would be talking to. So this is open to any primary care provider in the state of North Carolina. And we basically just provide curbside consultation for providers on helping them manage their patients that have mental health need. So this is some of the contact information for you that I wanted to put there. This is a little bit about how NC-PAL model works. Again, Chelsea Swanson is the person that really heads this up. She's our program manager for this grant, and it allows us to do a lot of these different activities. But she's a great resource if you have questions about using NC-PAL. And so this definitely, and treating anxiety disorders definitely falls under the umbrella of, what we can help providers with. And so we'd be very happy to do that as well. And yet again, so this is Chelsea's contact information. So I just put that there in case you wanted to reach out to her or have Karen reach out to her. And that is the end of my talk.
We're concluding our talk tonight, but we thank you for attending.